Today, let's discuss parathyroid hormone and related disorders. This content is for educational purposes only and is not medical advice. So let's say you have a patient in her 40s who suffered a hip fracture after a ground level fall. She mentions that she recently passed a renal stone a few days ago and all other history and physical exam is unremarkable. Her labs demonstrate elevated PTH, elevated serum calcium, and low phosphorus, while serum creatinine and albumin are all within normal limits. Her most recent DEXA scan reveals osteoporosis. She asks you for a scientific explanation for why this happened. How do you respond?
When you consider the various bone and PTH-related disorders on your differential list, it can be overwhelming to think about this chart. But let me break it down in a way that makes sense so that you don't have to rely on memorizing up and down arrows, but instead, apply what you understand to help get you more questions right on your board exams. So now let's explore the normal physiology of parathyroid hormone regulation, or PTH, a bit more. In order to understand the abnormal, we must first understand the norm. Physiologically, the role of PTH is to increase serum calcium whenever it detects low calcium or low vitamin D or elevated phosphate in the blood. Once PTH is secreted from the parathyroid glands, its downstream effects occur in the bone and in the kidneys. So in the bone, PTH stimulates the release of rank L from osteoblasts, and that binds the rank on bone osteoclasts. And this process then stimulates the osteoclasts to resorb bone, which releases calcium into the bloodstream. PTH also acts at the kidneys, in which more calcium gets reabsorbed while less calcium gets excreted through the urine, and vice versa. You also get less phosphate reabsorbed while more is excreted through the urine. And then PTH also promotes the activity of this enzyme here called 1-alpha hydroxylase. Whenever there is low phosphate around, vitamin D3, or what we call calcitriol, gets synthesized. You see that there is this one hydroxyl group added to vitamin D over here that was only hydroxylated at 25, but now with 125, we end up with a activated vitamin D that can further enhance the reabsorption by going to the gut, the small intestine, to reabsorb calcium and phosphate, as well as going to the bone matrix, degrading it down to release phosphate into the serum. So what's confusing and high yield to know is that PTH raises serum calcium but lowers phosphate levels. This is why it is helpful to remember PTH as your phosphate trashing hormone. It's confusing because PTH also promotes the synthesis of vitamin D, but recall that vitamin D raises both calcium and phosphate levels. And this trips students up on questions because that leaves us unclear on what the net effects are on lab values. But I think what would be helpful is if we stick to the primary insult. So for instance, in vitamin D deficiency, which leads to secondary hyperparathyroidism, the primary insult is always low vitamin D. So without vitamin D, you would have lower calcium levels and lower phosphate levels. And even if PTH is activated in response to try to raise that serum calcium, the net effect will still be high PTH, low calcium, low phosphate, and overall low vitamin D, even in the presence of increased parathyroid hormone. Now, if we compare these lab values to those found in chronic renal failure, we see that the primary insult rule still works. So in renal failure, the renal tubules that contain 1-alpha hydroxylase are shot. So there is a deficiency of vitamin D. Without vitamin D, calcium levels will again be low, and without working renal tubules to filter out phosphate retention occurs. This low calcium stimulates the compensatory release of parathyroid hormone, leading again to secondary hyperparathyroidism. However, even again with the actions of PTH at the bone and the kidneys, serum calcium will be normal or low at best, but it will never be elevated in this scenario, unless there was some sort of pharmacological intervention given. Again, the net effect will be high PTH, normal or low calcium, high phosphate, and again, low vitamin D, even in the presence of increased parathyroid hormone. So just remember, first focus on the primary insult, and everything else will occur downstream of this underlying problem as a compensatory mechanism. But these are never enough to fully correct the original problem. So, without intervention, you wouldn't see normal vitamin D levels in this situation, for instance. Another highly tested concept is the activation of bone osteoclasts during this process. Let's dive further into PTH effects on bone. In the schematic, we see that PTH binding stimulates the osteoblasts to release RINK ligand, or RINK-L, which activates RINK on these bone osteoclasts. They're sort of like baby osteoclasts that are termed osteoclast precursor cells, or OPCs. Once they bind, the OPCs then differentiate into mature osteoclasts. They've grown up and they're ready now to degrade bone matrix and release calcium back into the blood. Test writers want you to know this because the big picture is that bone osteoclast activation is not merely a simple, direct, one-step process, but an elegant multi-step process involving PTH, osteoblasts, and RINK activation. If we speculate further, this complex route is probably a protective mechanism that allows the body to tightly regulate osteoclastic activity before committing to bone resorption. And we see recurrent themes of homeostasis and balance all over the body. So it's not surprising that we see evidence of this in endocrine signaling as well. And now that we've seen the effects of PTH under normal physiological conditions, we can begin our review of disorders that occur when PTH regulation gets disrupted. So this simple graph here helps illustrate the pathophysiology when PTH is dysregulated. The graph shows PTH on the y-axis and serum calcium on the x-axis. So let's start with the normal range, when both PTH and calcium are in the middle. In this situation, the body's regulatory systems are working perfectly. And recall that in normal physiology, the regulatory calcium and PTH levels are governed by a negative feedback loop. Under normal conditions, the parathyroid glands monitor serum calcium levels. When calcium levels drop, the glands secrete PTH, which works to restore calcium levels by stimulating release from the bones, increasing reabsorption from the kidneys, enhancing vitamin D activity, which then increases intestinal absorption. And once calcium levels rise, negative feedback inhibits further PTH secretion. This feedback system is critical for maintaining calcium homeostasis, and its dysfunction then underlies different clinical scenarios that we see in the periphery. So as we move outward from the center, we begin to see how each of these scenarios lead to their downstream effects and lab values. For example, if we look over here to the top right, in primary hyperparathyroidism, the parathyroid gland in adenoma or hyperplasia or carcinoma independently secretes PTH independently from calcium. And this disrupts the feedback loop, causing hypercalcemia. The parathyroid gland then is what we call the primary source of the problem, hence primary hyperparathyroidism. In secondary hyperparathyroidism, over to the top left, persistently low calcium from vitamin D deficiency or renal failure can then cause a chronic PTH overproduction as a compensatory effort to correct the hypocalcemia. The elevated PTH is therefore a downstream sequelae of the primary problem that exists elsewhere in the body, like vitamin D deficiency. Hence, we call this secondary hyperparathyroidism. Moving over to the bottom right corner, we have PTH independent hypercalcemia. And in these scenarios, something like a malignancy or vitamin D toxicity can appropriately suppress PTH, leading to low PTH levels while still having a high calcium level. And down to the far left, we have true hypoparathyroidism, where there's typically some sort of glandular damage, either from post-surgical changes like a surgical resection or autoimmune destruction or infiltrative diseases like Wilson's disease. And these can all cause injury to the gland so that PTH production is lower than usual. And because of this, calcium levels also remain low due to a lack of compensatory response. So hence we call this a true hypoparathyroidism. So hopefully now that we've gone through the previous slide, this chart that I've represented won't be as daunting and formidable as it was the first time I put it up. We can maybe start to begin predicting the up and down arrows more easily now that we've talked through the physiology and mechanisms behind some of these disorders. So I'll do the first one. In primary hyperparathyroidism, we talked about how the parathyroid glands were your primary source of the problem, either from an adenoma, hyperplasia, or carcinoma. And so PTH should be continuously active and elevated. And therefore, you should see elevated PTH. And downstream of that, then are all the effects. Calcium should be elevated because PTH's job is to increase serum calcium. And PTH is known as your phosphate trashing hormone, so it should lower the phosphate levels in the serum. And anytime there is a lot of activity on the bone and overturning, alk phos tends to be high. So those numbers should be high, high, low, high. And if you ever have any trouble getting through these, read the pathophysiology and the mechanism and notes. Those sections hopefully will be helpful to guide you along in choosing some of the arrows for these. What about for secondary hyperparathyroidism as a result of renal failure? We talked about this one too, so good. The primary insult, again, is low vitamin D, right? We don't have 1-alpha hydroxylase, so there is lower levels of vitamin D, which means you'll have lower levels of calcium, and the kidneys are shot, so it has trouble with filtering out phosphate. So phosphate is retained. So you'll see elevated phosphate, and as a result, PTH is then stimulated to try to increase serum calcium and get rid of some of that phosphate. And again, alk phos will be elevated due to overturning of the bone. So as you go through these, think about the primary insult, and sometimes you may be really sure of one or two of them on a question stem, and maybe the last one or two you're not so sure about. So always work on process of elimination based on the up and down arrows that you're certain about, and typically it'll lead you to the right answer more often than not. Of course, there's going to be some nuances in these scenarios, but like I said, the primary insult always remains, right? Vitamin D will never be back to normal levels without some sort of intervention. And so even with, like in this renal failure situation, you could have normal levels of calcium because your parathyroid hormones are there to help you compensate so that you can get back to normal levels. But vitamin D levels, if this was part of the chart, if there was a column here, vitamin D would still be low. So just remember that. There are nuances, but there are also some things like the primary insult that for sure will be elevated or low. So we'll go through the rest of these. You can also hit pause when you work through this video on your own, And this could be a nice little exercise. I think once you get through these, you'll find that questions that come up on PTH disorders will be a lot easier to handle. So if we go back to our case presentation from the first few slides and we think about the lab values, the history of kidney stones, the osteoporosis, what do you think was her underlying problem and what imaging can you order to help with the diagnosis? That's right. So she has a classic case of primary hyperparathyroidism that presented with osteoporosis and kidney stones. And so we should touch upon what osteoporosis is to get a better understanding of the full presentation. And osteoporosis is basically low bone mass. It's defined as a bone mineral density with a T-score of less than or equal to 2.5 standard deviations at the total hip, femoral neck, and lumbar spine. And we classify it typically as a age-related bone loss or primary osteoporosis, or a secondary osteoporosis where the osteoporosis is due to some sort of underlying condition or medication, like in her case. So in our case presentation, PTH levels were elevated, and she had a case of hyperparathyroidism, which is a common endocrine cause of secondary osteoporosis. There are many different causes, in this situation, based on her lab values and presentation, we can suspect that the most common etiology for her was a parathyroid adenoma. And we can further localize that adenoma for surgical planning purposes with a scan and thyroid ultrasound. And typically, these adenomas are managed with resection. And then there are pharmacological regimens that we put the patients on as well, which we can talk about in future videos. So just to recap, to make sure we're clear and we understand the full presentation, how does hyperparathyroidism induce osteoporosis if PTH is normally around? And we mentioned that physiologically, PTH increases both bone formation and resorption, and there's this balance, but in pathological states where there's chronic excess of PTH, the balance is disrupted and resorption dominates. And then most of these cases are due to some sort of hyperfunctioning, autonomously secreting gland. And the resultant hypercalcemia induced by PTH can then lead to other classic symptoms as well, such as kidney stones, GI upset, cognitive slowing. And these are your typical stones, moans, bones, groans, psychiatric overtones. That would be the classical mnemonic to remember for this case. So that was basically it. There are multiple types of PTH and bone-related disorders, and the exam loves to test your understanding of the pathophysiology behind each of these various mechanisms. So I put this chart here at the end as a summary slide for you to study and review. We explored the classic presentation and mechanisms under primary hyperparathyroidism, secondary to adenoma. We saw that a patient can present with fractures, stones, and osteoporosis, and how chronically elevated PTH can lead to constitutively active osteoclastic activity, leading to bone resorption and all those findings. Hopefully this can be a helpful study aid for you. I'm sorry this video was so long. We will try to move a little faster through the next series. In future videos, I plan to discuss the treatment and management of this topic as a part of the series for step 1 through 3. If you found this breakdown helpful, please give the video a like, a thumbs up, and subscribe for more high-yield medical content. Leave a comment down below with any questions or future topics you'd like to see. I hope that was helpful. Thanks for watching.